Good afternoon and welcome to OGR's webinar, So You Think the Opioid Crisis Won't Impact You, How Funeral Directors Can Respond. My name is Jessica Smith and I'm the Assistant Executive Director for the International Order of the Golden Rule. OGR is an association for independently owned funeral homes, and we're so excited to be hosting this webinar today. I have Cheryl Moore on the line with me, and she's from the Erie County Department of Health, and I also have Charles Castilla of Lakeside Memorial Home on the line. So if you guys just want to say hi for a second.
Hi, how are you? This is Cheryl.
How's everyone? Good, I know.
So before we get started, I just want to have a couple of housekeeping tips for you guys. First of all, we'll have plenty of time for questions. If you have a question that occurs to you during the webinar, please type that into the question box or the chat box on your screen on your dashboard, and I will be monitoring those and we'll be answering those questions at the end of the webinar. Also, if you'd like a copy of today's presentation, it's been uploaded as a PDF, and you can also access that through the handout section of your dashboard. Before we get started, I would like to actually ask a poll to figure out who we have on the call with us today. So on your screen, you'll see a poll that is asking what position you hold at your place of employment. We have several, I know we have some association staff that are joining us, and we also have funeral directors and celebrants. So if you wouldn't mind selecting that answer, and I will share those results as soon as everyone responds. We've got about 75% of the people on the webinar today have voted, so I'm going to wait a few more seconds to try to get everybody's response in. Again, if you wouldn't mind selecting from one of those choices, that would be great. Okay, and the results are in. It looks like over close to half of the people participating are funeral directors, 25% are non-licensed funeral service professionals. Cheryl, we have no coroners right now on the webinar.
Okay.
And then people either from associations or from colleges or advisory boards, about 31% of the people participating. So without further ado, I'm going to hand this over to both you and Charles. And again, if you guys have questions, please type those in and I will be monitoring those.
Great. Hi, everyone. This is Charles Castilla. I'm the owner of Lakeside Memorial Funeral Home. And over the past year, we've seen a dramatic increase in the number of heroin overdoses and of deaths that we've had to serve families. It's been very draining for our team of employees because most of the people that we are serving are our family friends who lost their children. So it seems to be stressful more to our staff, not just because it's people we know, but it's also because of the tragic nature of these losses. We even had an incident where we had someone who passed away from a heroin overdose not that long ago, and at his wake, one of his friends was also addicted to heroin, came to the wake and stumbled into the casket. He was brought outside and then proceeded to overdose himself, although that person was able to be saved because we had called the police right away. They sent out first responders, and they were able to administer Narcan, and that person survived that particular incident. But we never had any losses of from heroin at our funeral home, and in the last year we've had one a month on average. So this is a dramatic change of events for us, and I had a lot of the misconceptions that many of the people have out there concerning heroin and its effect on people and how it impacts families and how it impacts the individual who has the addiction. One of our local churches provided a Narcan training seminar, which I brought several of my employees from the funeral home to, and Cheryl Moore, who is our presenter today, was the person who presented that day. And she did the program, and she's with the Erie County Department of Health, and she's a medical care administrator, and she has some personal experience also with this heroin overdose and addiction. So, with no further ado, I think that many of you are going to find out many of our preconceived notions regarding heroin are just that. They are preconceived notions that really don't matter, because what the reality is, you're going to find out in a second. So, everyone, this is Cheryl Moore. Thank you, Cheryl, for being here.
Thank you, Charles. Thank you so much for having me here. Once again, I'm Cheryl Moore. I'm from the Erie County Department of Health. I have a background in nursing. Before that, I have a degree in social work. Someday I'll have another degree in another area. Pretty well versed in this area of substance abuse and opioid addiction. As Charles said, I have a family member that we've lost also, so I can speak to it personally. And I want to thank you all for being on this call. That being said, we'll get started. So we're in the middle of an opioid epidemic. It is a public health epidemic. We've never seen anything like this. It's national. It's not just local. And I'm going to show you a lot of information today. So today's agenda, by the time we're done here in this next hour, a little bit under, we're going to know what addiction is, what the national trends are today, and our local community story here in Erie County, New York. And I'm going to show you how you could replicate it within your own community to address this epidemic. This epidemic is national. It's national and it's international, and it's taking people's lives at a rate like we haven't seen and I cannot remember. So let's talk about addiction. Addiction is not a choice, and this is something we need to understand. Addiction is a disease. It's a chronic disease. It's a disease of the brain. Your brain is changed. The addiction of opiate is like no other addiction. This drug is so strong, it literally hijacks your brain. People make decisions that are not rational. The drug makes decisions for them. This is reflected in how they are pathologically pursuing reward. Their relief is, they're looking for a relief of detox from substance use. Their behaviors are nothing that they would normally do every single day. It's characterized by an inability to abstain. Addiction, once again, as I will keep saying, is not a choice. It is a disease. There may have been a choice the first time someone took a substance of some type. But 75% of people that are addicted to opiates today, and opiates include heroin, prescription opiates that we make in a lab, we need to start thinking about is synthetic heroin. Because 75% of people addicted today started with these prescription opiates that were prescribed to them by their own provider. When they could no longer secure these, as in New York State with changes in our law, they've switched to heroin. Why do people use? Well, they used to feel good. They used to feel better. They used to do better. And they use out of curiosity. To feel good. Well, if you're in pain and you're prescribed an opioid, it takes the pain away. That also makes you feel better so you can function. To do better. You can do your job if you can physically move. And then we also have the curiosity. Young people, they always question, they experiment. And we're losing a lot of young people today. These are poppies. The poppy is where heroin comes from. These are the opiate poppy. The only opiate that we have today that is natural is heroin. It comes from a poppy. The rest of them we make in a lab. And we are fabulous chemists. We just keep making stronger and stronger opiates. And just keep in mind the whole time I speak today, opiates are opiates. Does not matter if it comes from a lab or it comes from a poppy. They all do the same thing. So what are opiates? Well, they're natural, they're synthetic, and they're functionally related to opium. This is the one that we get from a poppy. It takes some time. We grow poppies, we do something to them to get the drug out of them, and we create this substance we know as a community called heroin. In Western New York area, our heroin is tan. Other areas of the state, they have things called black tar, white china. It depends on China white. It depends on the areas that the heroin comes from. Opiate receptors are found throughout your whole body, especially in the brain, spinal cord, and GI tract. Their whole job is for opiates to land on. And when opiates land on them, their whole job, their therapeutic effect, is to take pain away. That's what they're there for. We all have them. We're all born with them. If we never use them, they just lay there, and they don't do anything. Another effect that opiates have on the brain is euphoria or pleasure. It affects our pleasure center initially. But afterwards, once you become dependent or addicted, you will never get that same pleasure from using the same drugs. And this is one of the theories, that people are always seeking that same pleasure. Long-term folks in opiate addiction never feel the same source of pleasure that we do every day. We get up in the morning, we're like, wow, what a beautiful sunrise. They no longer feel that. that is dulled due to opiate use. Other adverse effects, overdose from respiratory depression. People stop breathing and they die. These are some opiates here, and we'll talk a lot about them. These are prescription opiates: Lortab, OxyContin, morphine, fentanyl, the Duragesic patch, Opana, methadone. By no means all of them, but they all work on that same opiate receptor site as heroin. Heroin, it's processed from morphine, which is a naturally occurring substance. It's the only naturally occurring one. Pure heroin versus black tar, there's all different forms. The number of people using is astronomically on the rise, especially in the 18 to 25-year-old age group. We really didn't know why until we did a bunch of surveys around here. We've surveyed people on the street locally twice, and I know they've done the same thing from the CDC. We know today that 75% of people that are using heroin started using opiates with prescription drugs prescribed to them by a physician for something legitimate. Now, when the access to prescription drugs were no longer there, the disease of addiction was still there. The need, the physical need to keep from being sick. Someone that is in detox is experiencing, detox from opiates, is experiencing what others would describe as the flu, the real flu that you get a shot for, times 10. They feel that bad. They're trying to keep that away when they're using opiates. Why is heroin so addicting? Well, the increase in the dopamine and serotonin response is exponential. That's the feel-good, our natural feel-good that we have. With opiates, this happens almost immediately. If we're doing this naturally, it's because we're running and we release endorphins. We see something pleasurable and there's endorphins. Behaviors such as eating and sex release this. Unnaturally, we take some opiates and it's released immediately. Bam! And that feeling is fabulous. Other areas they affect. I mean, when you look at this is a pretty visual picture here. How drugs of abuse target the brain. Well, when we have food and they touch these dopamine receptor sites, it's sort of pleasurable. And I've used cocaine here as the example for pleasurability, but drugs are drugs. They all affect the same area. And when you look at that, all those little dots in there, look at the increase in the pleasure response with cocaine immediately. Food is somewhat. Cocaine, incredible. This is the response that we're seeking without even realizing what we're seeking. We want that pleasure. That's human nature. So, heroin, though, it alters how the brain functions. This is really scary. The brain actually changes. It makes adaptations. It takes larger amounts to get the same effect from heroin. Those opiate receptor sites that we have, the more we use opiates, we grow more opiate receptor sites. So we need more opiates to get the same response. So if we're on them 4 times a day for a month, we've grown more opiate receptor sites. And potentially we can become addicted. We didn't used to know a lot of this stuff when it came to prescription drugs or opiates as a whole, but we know a lot today. The evidence is there and the research has been done. 2.5 to 3 weeks appears to be the tipping point when someone becomes addicted. So if someone is prescribed 24-hour a day, 30-day supply of an opiate, the potential for addiction is very high. We also know it's about 1 in 4 that will become addicted. We didn't used to know these things. So national trends today. Before we start this, we have another poll. We wanted to ask you a few questions.
Okay, so on your screen, you'll see this second poll, and this is asking if you have provided services to a family experiencing the death of a loved one due to the opioid epidemic. The possible answers are yes, no, I don't know, or I'm not a funeral service professional. Looks like about 50% of you have voted, so I'm going to wait a few more seconds to try to get all those responses in. We're at 70% now, so keep on voting. Okay, Cheryl, 55% have, 10% aren't sure, and then we have that 35% who's not a funeral service professional, but they're here for educational purposes.
Thank you very much, and I will try to focus some of the comments to help you deal with these families. So, national trends today, what are we seeing nationally? This epidemic is across the whole country. We're experiencing 129 deaths every single day due to opioid overdoses. Translated, that's about 2.5 deaths per state every day in the nation. So each day, 46 people die from an overdose of prescription painkillers specifically. That's not including the heroin. We've gotten into this problem that we're in today because of prescription painkillers. Started out innocently, it has changed. Some of our highest prescribing states. This is a national map of the number of painkiller prescriptions per 100 people. When we look at these, some of our highest prescribing states are in the center of the country. New York State does not really look that bad, but our issue has transitioned over due to something called I-Stop to heroin. The rest of the states in the country, astronomical when we look at the purples. Look at Oklahoma, Arkansas, Louisiana, Mississippi, Alabama, Tennessee, Kentucky, Indiana, Ohio. I follow these trends. The death numbers there are astronomical, and this is due to opioid prescriptions. So, U.S. narcotics use. This is in 2010, which is 6 years ago, but data takes a long time to catch up with us. At that point, we knew we had 5% of the world's population. But we also wrote 95% of the world's hydrocodone prescriptions, 80% of the world's oxycodone prescriptions, and 65% of the world's hydromorphone prescriptions. For 5% of the population, that was ludicrous. Heroin then also increased. When people could not get the prescription opiates to make the sick go away from detox, they switched to heroin. Opiates are opiates, folks. They all land on the same receptor sites, and we just have to keep that in mind. So surprisingly, we started looking at heroin demographic increase. Historically, who we thought used heroin, who television portrayed, males, older, homeless. That's not who we're talking about today. These are the biggest groups. Females, 18 to 25. Non-Hispanic whites. All incomes. Nobody's special here. Folks that had no health insurance. Females that had private health insurance. This epidemic is different than anything we've ever seen. We also looked at deaths. 286% increase nationally. That is unbelievable and unacceptable. So, how did the opioid addictions epidemic begin? Well, in early 2000s, we saw a whole shift in prescribing practices by physicians. We have the pain scale, we have the smile and the sad, and we'll talk a lot about this. So we have Big Pharma's role, we have the patient's role, we have the physician's role, and we have the health plan's role. The physician's role. Well, U.S. doctors had prescribed it mostly for short-term pain. But it was around 1980, New England Journal of Medicine, there was a couple small publications, and in 1986 in the Pain Journal, they talked about these new opioids that had a low potential for addiction. Well, now we know they had a high potential for addiction, but at the time we were looking for a solution to problems. Pharmaceuticals role. They manufactured the narcotics. They aggressively marketed them. They funded studies. Purdue Pharma, Johnson & Johnson, Endo Pharmaceuticals. They promoted these prescriptions to docs. We have laws changed now. There's no more of these incentive programs. You know, you use my product, we take you to the Bahamas on a trip. That's gone now. They provided CME courses to docs to really get them to use these. Docs need continuing medical education to renew their licenses. This was very attractive to them. We've changed. Undercover marketing by Big Pharma. Like I said, they funded medical profession organizations to influence physicians. They published guidelines. They funded studies to publish guidelines. We now know that that was wrong, and we've changed what we do. And we're fixing it now, but we're really suffering the fallout. Pain management. In 2001, the Joint Commission issued pain management guidelines. If anyone's been to their primary care doc or if you've been in the hospital, you've seen this scale. We got in a lot of trouble from it. Smile, sad face. Everybody's perception of pain is different, and a little pain might not be a bad thing. So medicine on the take. Purdue Pharmaceutical, which is the manufacturer of OxyContin, funded a pain management educational program. The Joint Commission was involved. These are the people that rate our hospitals. It was kind of a ethical dilemma here. The Federation of State Medical Boards policy was to punish doctors for inadequately treating pain. We have the age of the internet. People get up there and they complain about their docs. Docs get cited. They were worried about that. We now understand that, as I will say once again, a little pain sometimes is not a bad thing. Brought Pharma to court. Changes were made. The patient's role in the addictions epidemic. People believe that we should have no pain. People believe that there is a pill to solve everything. The customer is always right mentality has been promoted by social media, and patients are really able to pressure their physicians into satisfy the request for pain pills. We now have laws in place in New York State which are not allowing that, but we did not have that before. The physician's role. Once again, very difficult for the docs to say no. Primary care office visits are brief. They don't know these people well. Doctors feel definitely poor patient survey ratings. This is a business, even though they're in it to take care of us. And dissatisfied patients, they file complaints. So the health plans roles. Well, they were involved in this too because they're the payers. They're the people who paid for all these scripts. They use patient satisfaction scores, reimbursement for increased patient visit time was challenged. It was much easier to write a prescription. It's very difficult to get the alternative services covered. Things like OT, massage, acupuncture. We're just starting to get them on the menu of services that are covered by insurers now. Long-term health effects of opiate addiction. Our society is suffering this now. When we look at our death rates, and this is national, our huge groups, when we look at our age groups from 25 to 54 years of age, it just keeps going up, 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 up. Opiates overall. Our highest heroin deaths in the 25 to 34-year-old age group. These are our friends' children. These are our friends. Drug poisoning deaths, opiate analgesics, CDC's tracking this stuff. As of 2013, it just kept going up. Heroin kept going up. We got a little leveling of the prescription piece, but then heroin jumped further. Men and women, it's the same. Women are jumping right up there to meet men. Drug poisoning deaths involving heroin in ages. If you look, the heroin numbers are younger. That 25 to 44, and it's going up astronomically in that age. The others were much more stable, but as of 2010, they're all going up. Drug poisoning deaths involving heroin by age and race and ethnicity. My point here is, and this is national data once again, between 2000 and 2013, that's only 13 years. Those numbers went crazy. We didn't pay close enough attention. This is in census region. The Northeast and the Midwest have been hit really, really hard. The South and the West, they're seeing it also. But as far as drug poisoning deaths involving heroin specifically, the Northeast and the Midwest have seen the biggest jumps. So the effectiveness of long-term opioid therapy. That's how we got in this mess today. We gave people pills for everything. Well, now we've studied it. And what we have learned is the evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function. We know this now. All these wraparound services need to be there. We need to treat the underlying issue. People will always have pain. Pain is a real thing, but we need to do more than just throw pills at it. So other things we have started to look at here. Increasing incidence of something called neonatal abstinence syndrome. That's a drug-addicted baby. These numbers are going up astronomically. When you look at 2004 to 2013, the number went up 4 times nationally. If we look at it in a graph format, It's very visible. And the crawl just keeps going up, and it's not leveling. What are they using in these babies to withdraw them? Because when they're born addicted, we have to use drugs to withdraw them. Right now, morphine's becoming more popular. Old school was methadone and phenobarbital. This is Buffalo, New York, just to show you one community, how our numbers have gone up from 2010 to 2015. In 2010, we had 12 admissions for neonatal abstinence syndrome. In 2015, we have 96. 2016, I can't even guess what it's going to be. At this point now, we have another short poll for you.
Okay, so this is looking at the most common way that people enter the opiate addiction. So from your perspective or what you know, would you think it's heroin, prescription drugs, or other street opiates? Got about 70% of you have answered, so we'll just wait a couple more seconds. And Cheryl, we've got 5% say heroin, 77% say prescription drugs, and 18% say other street opiates.
Okay, thank you. So let's speak to HIV and HCV. Well, we're talking about opiate addiction here. Opiate addiction ultimately, in the end, ends up with needle sharing and needle use. The two diseases we're speaking about here are bloodborne pathogens. They're transmitted through blood and bodily fluid products. Other areas of the country are seeing the evidence of this now. In Indiana, we just had an outbreak, a community outbreak of HIV. They opened a needle exchange to address this. When someone is addicted to opiates, they are really, really sick. Even if they know that it's not right to share needles or share their mechanism of taking the medication, that they may share disease, that's not the issue on their brain. The issue on their brain at that point, and their brain takes over, the drug takes over, is make the sick go away any way you can. Afterwards, they may think about it. But this brings to our attention here universal precautions, protecting ourselves, and not assuming because of who someone is, where they live, what kind of family they come from, that they don't have this type of bloodborne pathogen. HCV is not a baby boomer disease. It's what we're hearing all over the news. But with the transition of folks from prescription drugs to heroin, opiates are opiates, and the transition of snorting, ingesting, or smoking these drugs to using a needle to take them, our numbers of HCV, which is hepatitis C, and HIV will go up. The numbers of acute hepatitis C, 53% of the cases are among people in their 20s. You saw those numbers of deaths, that makes sense. 26% of the cases in their 30s, that met the same death numbers. So responding to the heroin epidemic, what are we doing here? What are we doing in the country? What are we doing in Erie County? What are we doing everywhere? Well, we're preventing, working on prevention. In New York State, we have something called iStop. It's a prescription monitoring program. Not every state in the country has something like this. There are a few that do. Massachusetts does. Other states are looking at something similar. In New York State, it's a real-time program where before iStop, which went in place January 2014, people could doctor shop here. They could go to multiple doctors in one day, and if they had great health insurance, they could get 6, 7, 8, 9 scripts for opiates in a day and actually get them paid for by their health insurance. Well, as of January 2014, that has all been cut off. Now it's about the individual, not their health insurance. People are looked up in a real-time, live, web-based system by both their provider and their pharmacist, and there's a limitation on prescriptions. 1 opioid prescription a month. That's it. So where people were getting 6 or 7, they're getting 1. They've transitioned to the street here to purchase opioids on the street. They're no longer accessible. If they are, they're very costly. This has led to the transition to heroin to take the sick away. So practitioners and pharmacists here, they're learning about this. They're learning every day. People are changing. It's not who we think of using heroin on the street today. It's anybody that you could possibly look at walking down the street. There's common elements for guidelines and prescribing opioids for chronic pain. That's one of our responses here because we got in trouble doing more prescriptions than we needed. We launched a combat heroin campaign here in New York State. It looks like this. Other states have picked up on the same thing. I was in Ohio a couple weeks ago, saw something very similar on their news. Erie County, New York. Here's our local response to the epidemic, and please feel free to take away anything from our response that can help you in your own community. Here this was brought to our attention in 2014. The death of Philip Seymour Hoffman in New York City. He was very well known, an actor. It was all over the news. He was actually from our area here, brought it to our attention. It's our neighbor, it's our child. It's everyone here. We can't pick up a newspaper without having a front page story every single day. One of the things we did, though, was take ownership of this. We have equipped our first responders, we've equipped our EMS, we've equipped our fire with naloxone, the tool to reverse overdoses. We've taken it to the next step, and I'll talk about that also. We've brought it to the community, we've brought it to the media, we've started to talk about it, and we have to keep talking about it. We have to break the stigma and talk about this addiction and this disease. This chronic disease. And what we have to also realize is no one woke up one day and said, I think I'll be an opiate addict. It wasn't their life plan. So our ODs keep increasing. It is nuts what we're seeing here. In Western New York, we were in Erie County specifically. We were one of the first to see the fentanyl issues here. We've had it around here for about 2 years. DEA released an alert about it about 3 months ago nationally. We looked at our deaths. This was brought to our attention in 2014. It took many years. We have a medical examiner system here, so all of our deaths are cleared through a toxicology screen. In 2014, it took until September 29th of 2015 to clear all the deaths of 14. We had 128 due to overdoses, 127 due to opioid overdoses. In 2015, on that date, we already had 118 deaths due to opioid overdoses. Scary thing there. Very scary thing. We looked at who people were because we had perceptions of who were using opiates, and it was different than anything we ever saw. In Erie County, New York, the city of Buffalo is urban. Everything else on that pie chart is suburban and rural. In the city of Buffalo, that's residents at time of death of the folks that died then. In the city of Buffalo, about half of those folks were suburban and rural residents seeking to purchase drugs in the city. We looked at what they died from. Fentanyl is huge. In this chart here in 2014, that other opioids, that's prescription drugs. They were still accessible. That's the year I-STOP went in place in Erie County, or in New York State. We transitioned quickly in 2015. We looked at who these folks were. It was really white disease, 92% white. Our average age of death was a 40-year-old white suburban male. It's crazy. Really male disease. We looked at what they died from. Fentanyl is popping up. The fentanyl we're talking about is a white powder that the cartels are using to cut heroin. We are hearing from folks, active users and their family members. You know, when people leave, they want to send people to the other side with something to take them there. If you find products in caskets, do not touch them. What we're talking about with the fentanyl is the equivalent of 3 grains of salt. We all know how much that is. That will kill a non-opiate user immediately. And this is what the cartels have taken as their drug of choice to cut heroin with. In Erie County, we're a mess. I'm being bluntly honest. We had 256 deaths in 2015 due to opioid overdoses. That's up from 128 the previous year. This year, in 2016, we have already cleared 100 bodies through toxicology screens due to opioid overdoses. And we probably have another 150 waiting for tox screens. It's not getting better quick. This is what people died from in 2015. If you look, that other opioid number went down significantly. That's prescription drugs. That's due to I-STOP. But that fentanyl number went up astronomically. That's the white powder they're cutting heroin with. This is a residence. It's very similar to 2014. What we have learned from this epidemic, it does not matter where you live. It does not matter how much money you make. It does not matter what you look like. This is affecting everybody across the board. It's becoming much more female. The disease is changing in 1 year. If you recall, it was about 20% female, 80% male. It's almost 30% female now. It's becoming much more diplomatic. It's affecting both genders, getting equaler each day. Race and gender. In Erie County, New York, we're a really white county. We're about 86% white, but the disease was even whiter. It was even whiter in 2014. It was about 92% white. But in 1 year to 2015, it's exactly mirroring the races and ethnicities of Erie County across the board.
Cheryl?
Yes.
Are you guys seeing these trends nationally and then even in Canada?
What we're learning in Canada, and I'm very close to the Fort Erie area here, they're just starting to see this in the Ontario province, more so in the Toronto area, because we've been working with their health ministry, is what it's called there, and we've also worked with a lot of their clinicians. The change in people's usage, in the change of ages, I think it's pretty similar. In 2015, if you look, it stayed pretty stable. This is our death data here, 16 to 83. What I'm showing you is mirroring a lot of the national data. When we go to the CDC, we're just blessed in Erie County. We have a medical examiner's office. Oh, I have 2015 and 2016 data. You're not going to get that nationally in state data. They're probably on 2014 or 13 at this point. It's usually a couple years old. So we've been able to take this and try to project what's going on. The point of this is it's affecting everybody across the board. It does not matter. I mean, when you look at this, 16 to 83. Other things we're doing in response here that you can do in your areas, you can work with folks in your community. We have needle and drug disposal boxes all over our community. This problem is initiated with prescription drugs. If you have extras in your home, get them out. They're too tempting to people. The other piece is when they transition to needles, and we've done surveys locally, and I know the information is going to be the same nationally. I know there's surveys occurring in other areas. They're all sharing needles. So if you have old needles in your home, get rid of them. This is just an example of what we do here. We have developed a web-based application that we could expand across the country. It's GPS-enabled. It's across the whole state of New York, where you can get rid of needles, drugs, pick up new needles, things like that. We've started a huge campaign, Just Say No. And we're not just talking about street drugs. We're talking about prescription drugs. Let's educate the patient. We don't need a pill for everything. Let's go to the doctor and say, hey, maybe there's another option we could try. Just say no. Responding again. Reversing heroin overdoses. Well, we're talking about naloxone, Narcan. In Erie County in New York State, it is legal under a shared access order for anyone 16 and up to have their own Narcan and to treat someone else with it. We're covered under the Good Samaritan law. There is no liability. It is the same law that protects you when you provide CPR to someone. It is first aid. We provide free community trainings from the county, and there's other organizations. I think we provide the biggest ones. This is what people get. We give them free kits. We get this from the New York State Department of Health. They've determined that this is such a public health epidemic, we need to save lives. The number of deaths that I showed you, I'm going to show you some maps of Narcan usage. And the number of deaths I showed you would probably be quintupled without the usage that we have today. This is nasal Narcan. That's what we use exclusively here in New York State. The needle is still being used in many other areas of the country. It's just a different way of delivering the same medication. We're sticking with nasal Narcan because everybody's sharing needles and they have those lovely bloodborne pathogens. We don't want them. So this is our type of, to give you an idea of things that we do. We register people. We have lots of trainings up there. We put them out there and we open them to everyone. This is my training team. I'm very proud of them. I had to show you. Oh, this is something I do want to show you. We have the best relationship with police. We have partnered on this. The head of the DEA, and I would really stress to you to reach out to them in your local communities. Our local special agent in charge has come out and said, we cannot arrest our way out of this epidemic. We have to treat our way out of it. So we have unique partners. We're partnering with people that have never been in the same room together. So think differently when you're talking to people. We teach people hands-on skills, and this is what I wanted to show you. This is the city of Buffalo. This is a Narcan administration map. The darker the reds means the more Narcan used. This is Erie County as a whole. And that little dotted line areas, that pullout I showed you, if we look at specific zip codes on this map, such as 14224, 14150 up in the top here, I don't know if you can see my arrow here, and 14224, 14217. If you look, they have low Narcan administration rates, but when I map their death rates, they have really high death rates if you refer back to those charts. It's a direct reflection of the ability to save lives. Treatment. If people do not get into treatment for opioid addiction, the outcomes are not good. Even if they are in treatment, it's an up and down process. You get to the top of the hill, you follow to the bottom of the valley. You get to the top of the hill. When you're addicted to opiates, it is a lifelong disease. It is a chronic disease. You must learn to manage it, take care of it, own it. Think of type 2 diabetes. That's the best analogy. A lifestyle-driven disease. You get it because we eat horribly as Americans and we don't exercise enough. And our glucose goes off the charts. We learn how to manage it and take care of it. Opioids are the same way. Lifestyle-driven disease. We were prescribed into it. 75% of people addicted today for something, and it was legitimate. But at this point now, the disease of addiction has overtaken the underlying condition. So current efforts in Erie County, New York, we've trained about 8,000, actually closer to 9,000 people now. We've solicited funding and been awarded to increase provider training. We are increasing treatment providers because there's not enough treatment, and this is reflected all over the country. We have learned this. Inpatient treatment, outpatient treatment, medication-assisted treatment, counseling, counselors, there's just not enough. We're developing new surveillance systems because we didn't catch this quick enough. And we're working on expanding, as I said, the treatment services, but it really is not happening quick enough. But we do have to send people through school. So other things that we're doing, we are modeling the Gloucester, Massachusetts program, the Perry program, in Erie County and Niagara County. We have two counties together. We call it REAP, Rapid Evaluation for Appropriate Placement. We have 13 police departments where you'll be able to show up and say, I'm done. I can't do this anymore. I need to get in treatment. It will not matter if you're still using and you still have drugs on you. They'll get you in treatment. This is something that funeral directors, referring people to things like this, finding out there are REAP Perry projects all over the country. If you search PAARI, they're all over the country. In Erie County, again, I wanted to share with you, we have an executive order. Our county executive has taken this to heart. This is executive order number 14, addressing this epidemic, declaring it an epidemic, and starting a task force. There's a New York State Heroin Epidemic Task Force, and our county executive is also on the National Heroin Epidemic Task Force. We are representing New York State and Erie County. There's representatives from all over the country, from Kentucky, Ohio, Missouri. The next meeting of the National Task Force is August 20th. We take back what we have learned to the task force. We're learning from them also. This is our local task force, and this is our breakdown. If there's something in your community, feel free to plagiarize, steal, take it. These are the areas we looked at in Erie County to say we have deficiencies and we need to fix stuff. So
Carol, would you go through that slide? Oh, sorry. I was going to say, could you kind of explain each role and how, say somebody is wanting to start a task force in their community,
yes.
Who would they contact? Could you go through each part of it?
You could contact me. I coordinate the full task force, and they all report to me, actually.
Okay. So you have
more than happy. You can contact me, and I can set you up. Let me go through each area real quick. REAP is the police area, Family Support, Heroin Opiate Prevention Engagement Project, Project HOPE. These are consumers. These are parents and family members who have lost people. Community education, They're doing a lot of community education event, resources for the community. They've developed a bunch of YouTube vignettes, provider education policy reform. We have changed provider practices here. Opioid prescribing practices are changing. We've advocated for an increase on the cap of the amount that a provider can have as a buprenorphine doc. That's changed at the national level. I mean, we've really tried to do things at a bigger level. We're working with the insurers to change how they reimburse. Hospitals and emergency departments, we've changed their policies. In all of our hospitals and emergency departments, if someone presents with an overdose, they leave there with Narcan in their hand because we know they're probably going to overdose again. Naloxone Access, I run that program. We get that out in the community, and I shared that with you. Treatment providers, we're changing what treatment does. At this point now, I mean, this has to be real-time treatment, and this is something to advocate for in your community. This is not something, a hold that thought disease. When someone is ready for treatment, it's then and now. It's not in a week.
Mm-hmm.
So this is our governor in New York State. This is Governor Cuomo. He came to Erie County, actually, to sign our opioid law. We've advocated for a 7-day limit on opioid prescriptions for acute pain. Nobody needs 90 Vicodin to get a tooth pulled. Lots of people have entered into addiction because they went to the dentist and they got a tooth out. I mean, crazy stuff. We've added more residential treatment beds here. Is it overnight? No, it's taking time. We're looking at increasing our buprenorphine providers, and also, this is the biggest barrier, and it probably is nationally, having parity of insurance reimbursement. So that when people are seeking treatment, the barrier of what your insurance will pay for is not the barrier to get treatment. So what can you do in your community? Well, if you have a local opiate task force, join it. Find them and join it. I would contact your local health department, your local mayor's office, your local county executive, town supervisor. This seems to be where these task forces are housed. If there isn't one, initiate a new opiate task force formation. People need to talk about this stuff. Investigate naloxone usage laws in your individual state. If it is applicable, get everybody trained. The more that is in the community, the more people we can save. This is critical. Opiate overdoses are breathing. This is about minutes, not in seconds, not about 10 minutes. Investigate Good Samaritan laws in your individual states. In New York State, we have the Good Samaritan law. There's many things under this umbrella. One of the critical things, though, under this umbrella is calling for help. People are protected. The person who calls for help in a person experiencing a drug or alcohol overdose is protected from charges for a plethora of items. The idea is to get people in for help. Don't let them die. Advocate for changes in the laws to increase access to treatment services. This is huge also. Changes in such as buprenorphine administration. We do have one level increased. It needs to be broadened wider. Research location and contact for family support. This is critical, and it may not even exist. As funeral directors and folks that are involved in the end results here, you could fill a huge gap by linking people to support or starting support groups for them. People that have lost a loved one to an opiate epidemic are blaming themselves. They think they did something wrong. There's all these factors here. They need support. They really need support. If you just have the resources in your homes to give to people, that would be incredible. Provide educational materials outside of the viewing areas for funeral participants to pick up if they desire, so they can do it subtly. People are very embarrassed still, and that's the key thing here. We need to break the stigma. As you see my last point, we have to talk about this epidemic and really understand that nobody woke up one day and said, I think I'll be a heroin addict. Can I answer any questions?
Yeah, one of the questions that came in was regarding an online resource to locate opioid treatment resources. Is there something that we can direct people to if they need more information on how they can start finding
Yes, it is SAMHSA, and I can send you a link to that if you would like that.
Okay.
I'd be more than happy to. That would be for national resources. Every state has a little different. If we know where that would be, in New York State, there's something called OASIS. But yeah, SAMHSA would be the national, and they will funnel you out to the correct resources in your own state.
Okay. And you kind of mentioned this earlier. Someone is asking about, I think they're talking specifically about New York State, saying that there aren't enough beds for treatment and what is being done to address this particular issue?
Well, we just had funds allocated for beds, and we are, building them now, literally building them all. That is in New York State. Now, the other part of the issue is not everybody needs inpatient treatment. They may want it, but not everybody needs it. Many people will do very, very well with intensive outpatient treatment, and we just have to also understand that and work with families and users themselves to get them to understand that. Part of our population today is what we call a functional addict. Think of a functional alcoholic. They go to work every day. Actually, it's the majority of our population. The overdose occurrences, because I get the Narcan reports, the majority of them that we're seeing are between 4 and 8 in the morning and 4 and 8 at night.
Okay. And speaking of Narcan, another question that came in, do those who administer Narcan to others as an emergency put themselves at risk of liability?
No. In New York State, you're covered under the Good Samaritan law. It's no different than performing CPR. If you've been trained in Narcan administration, you're not liable if you administer, and you're not liable if you don't administer. Because that's always a question people have. If I was trained, do I have to do this? No, you don't have to.
So maybe people need to check their state law.
Absolutely. Check every state individually, and the laws are changing every day. So just because it says one thing today, give it a week. It may change.
Okay. And then somebody had asked earlier, was there a chart of deaths that's broken by race and by state? And I don't know if you have that in your PowerPoint, or is there a resource that you can point them to where they could find that? A
chart of deaths by race and state? The CDC will have that. It'll be cdc.gov. I think I put one up, but not the bigger one. It's www.cdc.gov.
Okay. And let's see.
Understand the CDC data is a couple years old.
So it's not keeping up necessarily, or it doesn't have this year or last year's information.
Right. It takes a couple years.
And then another question that just came in, you were talking about having some information in the home about treatment options for families who've experienced the loss. But should you ever approach or offer anything if you find out a family has family member needs help? So I guess maybe more directly interacting with the family than just having a brochure.
Absolutely. If you are comfortable speaking to them, absolutely, because you may be the thing that saves their life.
Okay.
Absolutely. That is, you hit the nail on the head here. We need to talk and not be embarrassed or afraid. We need to talk about this and just understand it's a chronic disease. It just is what it is.
And I know Charles had to get off the call with us, but wasn't he saying that there was a family that told him that their loved one had passed away, and it was because, I'm trying to remember what it was. They were lying about the cause of death?
Yeah, absolutely. Of a very benign disease, a very benign. And we hear this all the time. I do the trainings. I have family members in. They don't even know. I can tell you a story, a family member who identified how she found out her son was using. It was in a training. She thought he was drunk. Told us all about it. Told us that she was shaking him around by his beard and telling him, wake up, and she swept her hand under the bed and came out with a needle in her finger.
Oh, my God.
So this is everywhere, and family members, we want to believe things, but really be aware, and I can't stress enough, be aware. Know what's going on. If you don't know what's going on, ask questions. Do the research, and don't always believe what things are at face value, because they may not always be true.
And that needle comment that you just made actually goes in line with another question that just came in. What should embalmers be aware of when they're caring for the deceased of an opiate overdose?
Okay. I would be very careful. I mean, follow all universal precautions as you've been trained in. If you do happen to get bodily fluids into your system, you get poked by something, you need to get to your hospital and get treatment right away, the same as you would for anything else. We don't know what's in everyone's system, but we do know that the majority of them do have hepatitis C, and HIV is never far behind.
So those universal precautions are very serious to make sure that
critical.
you're following.
Don't ever slack. Always universal precautions, because you don't know. And this person we're speaking of today, you don't know who it is. It's not the homeless person on the street.
Right. There's somebody else who asked for a national resource or even just a maybe state resource where they could find information to give out at their funeral home. So maybe a pamphlet on what opiates are and
absolutely.
You could point people to.
Would you like me to send you some resources and you can put them up on the site for everyone?
That would be great.
I'd be happy to.
Today's slides are available to be downloaded through the handout section of the dashboard. So if you guys are interested in seeing her PowerPoint in its entirety, just click on that and download that. Tomorrow I'm going to be sending out a follow-up email to this webinar, and I'll include all the links to the resources that you guys asked about, as well as a copy of the recording. So if you're interested in watching this again or sharing this with people, you'll be able to do that. So I wanted to thank everybody so much for participating in today's webinar. Again, Cheryl's information is on the screen, so if you have questions that you'd like to ask her directly, please email her, and she'll be more than happy, or give her a call. She'll be more than happy to help with that. Cheryl, do you have anything else that you'd like to say?
I'd be happy to send you those resources, and thank you so much for having me on here, and thank you for what you're doing. We really appreciate it.
Yeah, well, we think it's really important to get this information out to not just OGR members, but to funeral service professionals as a whole. And we know it's not just happening in the U.S. We know it's happening in Canada.
Right.
So
Blackstone really rules are different in Canada. I can speak to that also. Just FYI. It has to be prescribed to the individual. It's because of the socialized medicine concept. So if you know you have someone up there that has an issue, it has to be prescribed to the individual, and you can't take it to Canada if you got it here from the U.S.
Okay, well, thank you so much, Cheryl. And everybody, if you wouldn't mind staying on the line, I'm going to end the webinar. It'll pop up, and it'll just let us know if you have any other additional questions, and let us know how we did today.
Thank you.
Thank you so much.
Thanks.
Bye.